Namaste. We are now on the 10th module of this course on patient safety and clinical risk management. We last saw the role of infection prevention and control in patient safety. We understood the hows and whys of proper hand hygiene, the 5 moments of hand hygiene, the proper use and disposal of sharps, and the proper use of personal protective equipment. We shall now shift our focus to invasive procedures and how we can ensure patient safety when patients are undergoing diagnostic or therapeutic procedures or surgeries. The learning objectives of this particular module include understanding the main causes of adverse events during surgical and invasive procedures and how using guidelines and verification processes with teamwork can reduce the risk of incorrect patient or incorrect treatment related errors. Now, errors during procedures and surgeries are not at all an uncommon occurrence. Among several, I found a 2018 news write-up describing how a surgeon opened up the wrong patient's leg for an orthopedic surgery in New Delhi. And in the same article, it was highlighted how some doctors missed diagnosing hypertension in a patient who suffered a cardiac arrest subsequently and died, how a patient received dialysis wrongfully in one of India's premier institutes, and how premature twins were declared dead although one was still alive. The problem in most of the times is the person approach. That makes people cover up such errors, and so we fail to appreciate the true magnitude of the problem and to learn from them. Nowadays, print and television media are very prompt in reporting medical errors, and so more and more number of errors are coming into the limelight. The most common adverse events associated with invasive procedures, including surgeries, are infections, poor hand hygiene or lack of standard protocols, or inadequate use of timely antibiotic prophylaxis are all recognized causes. Poor patient management, including handovers, poor communication in the workplace, inadequate conflict management skills, and poor teamwork. Poor availability of resources such as manpower, equipment, supplies, failure to use evidence-based methods, overworked staff, burdened wards, burdened ICUs, and frequently immunocompromised patients. All of these things come together and result in compromise in patient safety. Lack of supervision, especially in large teaching institutes, often puts patient safety at risk. What about the fact that surgeries are often complex and they also have to be performed under immense stress? So communication failures occur extremely frequently and include inadequate information, miscommunications, wrong information, and sometimes even lack of cooperation between staff and departments as well. In this module, you have been provided a link to an article detailing a real story of a patient who underwent a procedure scheduled for someone else. Going through that case conference will highlight to you how humans are capable of errors, and despite our best intentions, healthcare professionals do end up making mistakes which harm the patients. Now, in order to ensure safer healthcare delivery, we often hear the term evidence-based medicine or EBM. In order to practice EBM, it is our responsibility to keep updated regarding current guidelines and protocols. What are guidelines? Guidelines are published documents designed to guide clinical decision making. They are generally created by experts in the field after going through robust literature and are endorsed by national and international professional bodies. For example, the Indian Academy of Pediatrics or the Indian Psychiatric Society. Healthcare organizations must provide easy access to guidelines for all of its staff by making it available in departmental libraries and as well as on online platforms. Staff must also be encouraged to utilize them, and adaptations of the guidelines to suit local needs and availability of resources must be encouraged. Medical and nursing students must be aware of the existence of these guidelines. Students most often do not see their seniors referring to guidelines during practice. This creates a false belief among them that healthcare professionals remember everything off the top of their heads. and they also fail to recognize when decision-making errors occur. An example of a surgical guideline is the Joint Commission on Accreditation of Healthcare Organizations JCAHO's Universal Protocol, which is available to go through in the case conference article on wrong person, wrong procedure in this module. The use of checklists has largely transformed aviation safety. We touched upon this briefly during the earlier modules of the course. The origin of the humble checklist was also shared in the form of an excerpt from Dr. Atul Gawande's famous publication, The Checklist Manifesto. It is an interesting read and I encourage you to go through it if you missed it. Surgical briefings, debriefings and timeouts increase the patient safety during invasive procedures. The surgical safety checklist includes a list of items which are actions to be performed before induction of anesthesia, before incising the skin, and before the patient leaves the OT. These steps are often termed the sign-in, the timeout, and sign-out, and together they take no more than 4 to 5 minutes. Before induction, we need to make sure that the patient identity is confirmed, often using a 2 or 3-way identification process, which may include the patient's complete name, their date of birth, and their patient ID number or inpatient number. Ensuring appropriate consent is taken, correct procedure and site are confirmed. Checking if the patient has any allergies is also a part of the sign-in. After the patient is anesthetized and before incision is made, all staff must confirm their roles, the procedure, and the anticipated critical events during the procedure. The detailed checklist is available to you in the handouts of this module. Please feel free to print them and use them even if you are not part of a surgical team. Use the checklist to observe whether these elements are being used at your own workplace. Encourage staff you work with to consider using the checklist. Use of surgical checklists have demonstrated a reduction of potentially lethal adverse events by up to 30 to 40%. Being part of team briefings pre-operatively and debriefings post-operatively are valuable learning experiences for all of us. Share information appropriately, ask questions routinely, assert yourself, clearly state your intentions. These are all methods that help reduce ambiguity in the surgical or procedural communications. Participate in the surgical teaching learning process by taking on opportunities for hands-on experiences under appropriate supervision. So we often hear of mortality and morbidity meetings. These are confidential departmental audits where errors are discussed. The primary intentions of these meetings is to allow peer review of the events and discuss the lessons that can be learned from them. This way, staff learn from errors and can work towards improving patient safety. Such meetings may be held weekly, fortnightly, or monthly. It allows record keeping of events and also acts like small-scale root cause analyses which can be followed up by PDSA cycles for change. If you request, you may be allowed to participate in these meetings at your workplace. Observe if the meetings are conducted in a structured manner. Is the emphasis on a systems approach or a person approach? Is the goal preventing a future error or punishing someone? Is everybody involved in this meeting? Is it a core activity in the department? Are juniors and students allowed to attend? How do they handle deaths in these meetings? Do the participating staff feel supported? Is there any form of documentation of the events of this meeting? These are all elements that you can actually observe in these mortality and morbidity meetings. Whatever you observe in the surgical setups within your workplace, take away the desirable points and enhance your own surgical safety and surgical outcomes by following guidelines, checklists, and surgical best practices. Stick to protocols, practice verification of patients, procedures, documents, and other elements habitually in your daily practice. With this, I end this lecture. I shall see you in the next module of this course on medication safety. Thank you.